Hello, 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 and welcome back to the Critical Care Practitioner. Really excited to have two very special guests with me this episode. We are going to be talking about ECMO and all the ins and outs of it. I'm going to let my guests introduce themselves first, and then I'll tell you why we're talking about ECMO, and I'm going to pick their brains, and hopefully we're going to learn an awful lot about the referral pathway, what happens to the patient before they go, as they go, and once they arrive. Susan, why don't you introduce yourself first?
So hello, my name's Susan Dashey. I'm one of the ECMO consultants at Glenfield Hospital in Leicester.
Excellent. And Brij?
So hi, my name is Brij Patel. I'm one of the ICU and ECMO consultants at the Royal Brompton Hospital, and I'm also the research lead for ICU at the Brompton. So nice to be part of this.
Excellent. And the reason that we've come to this point and having this conversation is that I work at Warwick Hospital, which is a small DGH, obviously in Warwickshire. And probably about a month or two ago, we had a patient who was in severe ARDS and referred to Glenfield to see whether they could take him down their ECMO pathway. Now, he didn't go, but that's not really the point. The point being that I was very interested then. It wasn't me that referred. It was a junior doctor that ended up having a conversation with the person on the other end about this particular patient. And that just made me think, okay, what is the referral pathway? What do places like Glenfield and Brompton, is it just, by the way, Brij, because I did my intensive care course at Harefield Hospital, so is it just the Brompton that does ECMO, or do they go to Harefield at all?
No, so we do. So we're all part of one organisation, as you all know. So we both sites do extracorporeal support. However, the majority of the respiratory failure and ARDS retrieval services run through the Brompton, and effectively the Harefield do the bridge to transplantation and long-term cardiac support, if you see what I mean. So the acute retrieval team is from the Brompton, and the ARDS on the commissioned pathway, which I'm sure we'll talk about, comes to the Brompton, but also if we retrieve someone on a transplant list, we'll retrieve them to the Harefield. So both sites are doing extracorporeal support for different cohorts of patients.
Yeah. Okay. And then the other sites around the country, there's one in Manchester, I believe. Where are the other places? I did have a look at the map this morning, but I can't remember where the others are now. So
there's us at Glenfield, Brompton, as we already said. There's Guy's and Tommy's. There's Papworth, and then there is Manchester.
Papworth, of course, yeah.
5 in the UK, and obviously Glenfield also covers Scotland and Northern Ireland.
Okay, so that sounds like a fairly big area. Okay, so let's start by talking about, and maybe Brij, you can answer this question for me. Your typical patients, and Susan did send me a PowerPoint presentation of the kinds of patients that you get, but what probably forms the larger portion of the patients you get referred for ECMO, would you say?
So the majority of patients at the moment within the UK that are referred to us are those with severe acute respiratory distress syndrome, and most of those are infectious in origin, so mostly pneumonias, which have got so severe that they end up the referring centres refer to us because they cannot manage them what we would call conventionally, so with conventional intensive care and invasive mechanical ventilation. So the majority of cases are of those etiologies, so bacterial and especially viral pneumonias, particularly during winter seasons, are common. But also we are getting more referrals for instance, asthma. So we've had quite a significant number of asthma patients who have come through our pathway who have got severe type 2 respiratory failure, mainly a carbon dioxide problem within their blood gases with high peak pressures, and they also are referred within our pathway. Other sorts of patients include, as I previously mentioned, the bridge to transplant patients that are already on the transplant list, so cystic fibrotics predominantly. We would a lot of the time put on awake ECMO and retrieved to the hairfield. And also we have quite a close relationship with our interstitial lung disease team and pulmonary fibrosis teams. So they have their patients that are they would like to retrieve, that have got an acute exacerbation of their ILD, that they would like to bring to us from referring centres with a view to immunomodulatory treatment. And so there's I think the original kind of workup and patients that are commissioned through the National Commission pathway are mainly severe type 1 respiratory failure with ARDS, but I would say.
Okay, and maybe Susan, you can talk a little bit about some of the history of the extracorporeal oxygenation support as we've gone on. I mean, is this something that's been? I mean, I probably first encountered it when I was at Glenfield 15 years ago, and it was reasonably in its infancy in this country, certainly at the time, although the service had been developed quite well by that point. How long has this kind of treatment been around?
Can you still hear me?
Yeah.
Oh, sorry, I thought I'd lost you then.
No.
So the sort of first successful treatment was in the 70s, and Bartlett, who is sort of the founder of ECMO, sort of did his first sort of neonatal survival in 1975. So it was very established in the neonatal population much earlier than in the adult population. At Glenfield, ECMO was established in 1989, again with predominance towards the neonatal and paediatric population. And then over that time, obviously the adult workload has obviously crept in. The results have become better with better equipment, better circuits, better cannulas that have allowed that extracorporeal circuit support to extend into the adult population with improving results.
Okay, so let's think about if we go back a little bit to the ARDS patient. Let's talk about an ARDS patient to start with, because this is something that I've encountered more often than the other conditions we talked about. So let's talk about that initially. The ARDS patient, what would you expect of a referring center, or what would you like from a referring center? What would you like them to have done to their ARDS patient to ensure that their care has been optimized before they're referred to you? So when you're on the phone to them, what questions would you be asking them about their prior treatment that would make you believe that perhaps ECMO was the now the resort that they were having to turn to? Brij, maybe I can ask you that question.
So I think it's important to say that the centres that are currently in the UK, and particularly for the way we regard our service, is that we are a severe respiratory failure service with an ECMO arm that is present. So because we cover around, I think we cover around 42 hospitals in our patch, and each of the hospitals have different capabilities of managing patients, because their intensive care is quite a complex intervention with training needs as well as staffing needs. And so we've learned a lot as to which centres are capable of doing which aspects, certain aspects of care for an ARDS patient. And I think the first approach is that relationship and the transparency, is that it's not about not being able to do certain things. It's about doing what's right for the patient, if you see what I mean. Mm-hmm. And so when we start, our referral process is an online process. And so the Royal Brompton has developed a referral portal called Hospital to Home, which was used for long-term ventilation for the paediatric population we have, but we've transported that across to the ECMO referral service. So within the ECMO referral, the referring hospital fills out effectively a history and exam and all the physiological parameters that you would see at the bed space. and with that, we can have a very open conversation with the same information in front of us, with respect to what the severity of illness of that patient is currently at. And so prior to this, we would go through effectively all of the organ systems. So go through a history, go through the examination, but also go through all the organ systems, in particular the mechanical ventilatory support and the respiratory physiology that patient is currently undergoing. And then we'd go through a conversation as to what management has been implemented and whether it's safe enough to implement that. So, for instance, low PEEP, high PEEP strategies, the implementation primarily, first of all, of low tidal volume ventilation, whether the patient has been paralyzed using actinium or an equivalent, and whether the patient would then is so severe that potentially proning would be an option. And so we'd go through a step-by-step.
How severe do you mean? What is your criteria for severity?
So we again use the Berlin definition. So I use the Berlin definition in terms of severity because I think that's been devised and implemented, and a lot of people have seen the chart of the green, amber and red, and the various aspects of the adjunctive therapies that are added onto into each of those into each of the severities of ARDS. But I think it's important for us as well. So we as a team also need to gauge trajectory of illness. And that's an important aspect to try and get over the phone, which can be quite difficult. So radiological changes, but also physiological changes. Some patients deteriorate very quickly within 12 to 24 hours, such that actually by the time we get to the referring center, they've gone from what was mild ARDS, intubated, ventilated, to quite severe ARDS. Whereas other patients take maybe a few days and are slightly later referral because actually the referring center can manage it. So there's quite a lot of, I guess there's a big dynamic into each individual patient. And so what we would try to do is try and personalize and get an idea of trajectory, but also how quickly people, the referring center will be able to implement the adjunctive interventions.
Okay. Susan, because obviously once you've made this phone call and you've had this conversation with people over the phone, I can see that the referral paperwork is quite involved. You do ask a lot of questions, and quite right, because obviously coming over with the retrieval team, a big commitment. Once you've come, when you leave with the commitment with the retrieval team, how sure are you that actually you're going to be bringing that patient back? At what point do you say, okay, this seems like an appropriate referral, we're coming now? Does that always mean that you'll be coming back?
So again, that's very dependent on each individual patient. It will also depend on how thorough the history we've been able to get is. One of the really important things that we try and glean from our referring centres is what's the reversibility of this insult, and sometimes that's difficult to know, but also what's the patient's baseline, and often that's quite difficult to be certain of, and sometimes obviously extra information comes to light whilst we're making that decision and being en route to the patient. But usually if we're setting off to retrieve a patient, we will either set off conventionally to plan to bring them back as a conventional retrieval, because we think that we may be able to offer more in our severe acute respiratory failure centre that a general ICU unit, a DGH per se, would be able to offer and be comfortable with doing. Or we set off with the view that this patient is very likely to need ECMO, and therefore will take a perfusionist and also obviously all our cannulation equipment with us.
Okay, just to go back a point, go back a point there slightly, Susan. You say you might be able to offer more support than a conventional DGH. What kind of things are you talking about there? So you're not necessarily, you're not going to necessarily take the patient back on ECMO, you're going to take them back and do something else for them. What kind of things can you do that a DGH, as you say, may not be so comfortable performing?
So again, goes back to what Brij was mentioning, is it depends on the level of comfort of lots of our referring centres. Some centres will be very comfortable doing lots of advanced respiratory techniques using different modes of ventilation, for example. Some will find that much more challenging and it's not something they're familiar with. And so we have to gauge also the referring hospital's level of comfort. And if the patient is, gases are slightly borderline, but we think there are things that we could do, such as prone them, but also dry them out much more aggressively, try those different ventilatory strategies, echo them and do a TOE. Sometimes, we need to make sure that we are treating the right thing. Sometimes we're barking up the wrong tree, as it were, so we need to make sure we're sure of our diagnosis. We may also be more comfortable because we look after these sorts of patients more frequently. Be much more happy to take patients through a CT scan, for example, because again, we're used to moving these very, very sick patients, whereas some of our referring centres might be very uncomfortable with that, and rightly so. They aren't doing this sort of workload on a daily basis. Okay,
so for example, I call you, I refer a patient, and I haven't yet proned that patient. Is proning the patient, I know this is not necessarily in black and white, is proning the patient something you would always advise before you then start moving higher up the chain? Is proning always the answer, I guess, is what I'm asking?
So no, I think proning isn't always the answer. I think it is something that can be used in the right patients and get a response. Sometimes the referring centre, when they're talking to me, say, "Oh, shall I prone the patient?" And sometimes there's good reasons not to, particularly if the patient's very hemodynamically compromised with severe sepsis and they're needing lots of inotropic or vasopressor support. Then proning them may make them even more unstable, and then you might end up in a sort of downward spiral. So it's not an absolute for everybody. And also, some centres aren't used to proning. The nursing staff aren't used to nursing the patients prone. And so they are at risk of increased risk of pressure sores and other things. So that really does have to be also taken into consideration. But in the right patient, in whom appears on a chest X-ray to have dependent consolidation, it is certainly something we'd be encouraging centres to try if we felt that there was room to wait and see and have that wait and see approach.
So by dependent consolidation, you mean a consolidation in the dorsal aspect of the lung in particular? Yeah. Okay. So Brij, okay. So I've proned my patient. How do I know when that proning has worked? I put them on their front. I have got down on their oxygen a little bit. I think the current advice is we aim for 16 hours per prone. Am I right in saying that?
Yeah, no, that's right. So if we look at kind of the Preferable trial that Claude Garand kind of and the Preferable study group kind of completed a few years ago now, I think 2013. I mean, those centres in France were very used to proning, and they applied prone position very early, within 48 hours of ARDS, and found a really huge mortality benefit as a result of that. And what you would see in our experience of proning, actually, you'd see a response pretty much within 60 minutes, because it's an immediate homogenization of that ventilation perfusion mismatch that was present when patients were supine. And so you do see that response pretty quickly. But again, when it does happen, when patients are prone, there's not enough evidence. I mean, it changes physiology and it improves your PF ratio. It improves the way in which ventilation is delivered throughout the lung parenchyma itself. And so there's a huge benefit in terms of ventilator-associated lung injury as a result of proning. We don't have enough evidence to say that it modulates the disease process. So the disease process continues.
Yeah.
And so it takes me back to that trajectory. if there is significant consolidation and it's going within 12, 24 hours, then that patient may not respond as aggressively to proning, or during the proning period, they deteriorate. But what I think what a lot of ICUs also don't do, and where we do that a lot here in terms of educating internally as well as externally, is reevaluate the ventilator parameters. So a lot of patients are proned and they stay on the same ventilator settings. Whereas actually once you've proned, the respiratory mechanics change so considerably that actually you need to reevaluate where the pressure volume curve, where the optimal place is on the pressure volume curve. And I think that's an important aspect that's also underestimated.
So when, just to clarify, when you say that, we're talking about altering the level of Peep, for example. Is that what you mean by that?
Absolutely. Yeah. Absolutely. You know, the level of Peep is very controversial still, and recruitment maneuvers are even more controversial now. But I think, you know, the open lung strategy works to maintain lung recruitment, maintain oxygenation. However, we know from when we retrieve our patients, as soon as we enter the hospital doors, we go to CT before we go into the ICU, and we know that there's significant variability in recruitability of that dependent consolidation. Some patients that have such severe consolidation, not throughout the parenchyma, but just the density of consolidation, that even a Peep of, you know, Aprv at a Peep of 40 does not open up that lung. And what you end up doing is effectively increasing your dead space by over distending the aerated portion. And so that's probably a lot of the reasons why the Peep trials have been, you know, effectively significantly equivocal in a way, and not really given us the real signals in survival that we would intuitively expect them to.
So when you, let me get this right, because this is kind of the point of my whole conversation here, is that when you arrive at my unit with your transfer team, what is it you're going to do to that patient once you arrive? Susan?
So when we arrive at the patient, we will spend some time obviously taking handover from the clinician caring for the patient. We will make a thorough assessment of the patient ourselves. We will obviously look at the ventilation strategy and see whether there is something that we think, that's the issue, or, you know, is just a fresh pair of eyes enough to turn the tide. Often that's not the case. Often the ICU clinicians obviously been working very hard with these patients and have given us the full story. And it really is then a case of deciding how we're going to transport the patient, chatting to the families, gaining a scent for ECMO cannulation treatment and transport to obviously one of the respiratory failure centres. So whilst we do all of that, usually our perfusionist will go to theatre and start readying the theatre team for our arrival. And so we'll obviously, once the family have had a brief moment with the patient, we'll then transfer the patient round to theatre ready for cannulation. Okay,
so one of the things that you're going to need then presumably is a full theatre team. You come with a perfusionist. You come with the ability to place the lines. What about the theatre team at the hospital? Presumably, are they going to get involved, or is this something that you are able to do as a unit yourselves?
So I think both units do something slightly differently. So I'll explain what we do from Glenfield. So we take a team of 3 people. So the ECMO cannulator, the ECMO specialist, who's a nurse by background but very experienced in looking after ECMO circuits, and also the perfusionist. So we'll then obviously take the patient through to theatre, which will obviously involve the intensive care nurses and the intensive care clinician. And we ask the ICU team to do things like make sure the patient's cross-matched, portable ventilator available if we think that that's useful, or whether we can move them around to theatre on the ICU ventilator. Make sure we've got plenty of sedation and all the infusion pumps. Make sure that we've got enough to last us A, through theatre, and B, for the journey home. And really helpfully make sure that all the practicalities of the notes being copied, the drug chart being copied, so that we aren't delaying when we are ready to leave. Things that we ask for in theatre is an anaesthetist to help us, because obviously once we are scrubbed, we become the operator and we're no longer the anaesthetist intensivist. So we do need someone to look after the patient for us. We do need a scrub nurse. Sometimes they look slightly terrified because we're asking them to scrub for a procedure they've never seen before, let alone assisted with before. So obviously we spend some time talking through what we'll do with them. It's also then obviously useful to have an ODP, a runner who's familiar with that theatre, where things live in that theatre, so that if we do need extra things, that's useful. And then we also need a radiographer who's happy to use a C-arm and screen for us in theatre whilst we place wires, and then obviously subsequently the cannula. So we do, whilst we come with the essential people we need, it's a very much team approach with the ICU and theatre teams at the referring hospital.
Okay, so with a little bit of help, this is something that can be carried out at the referring hospital in all cases, presumably. Yes,
so occasionally it's felt that the patient is too unwell to go around to theatre, and we will modify our technique and do that on the ICU, but it is, of course, preferable to do that in theatre with more help on flat on an operating table and all those things that generally just make surgery easier.
Yeah, okay. And I imagine this is something that the family need to be informed about in great depth and detail as well, because I would imagine they have a lot of questions about the processes that the patient's going to be going through. Because like you say, these patients tend to become sick very quickly, don't they, Brij?
Yeah, no, absolutely. I think one of the discussion points with the family is significantly the risk of transport before, this is prior to ECMO, and during the process itself, because most of the time when patients are prone, you know, if we get there and the patient's sitting up, ventilated, but obviously at a 35-40 degree angle in his or her bed, or they can be prone such that we would have to deprone them to try and get them across. So as soon as they are supined, then the effect of proning disappears relatively quickly. It's very unpredictable sometimes. But just the effect of being on a theatre table flat does compromise the respiratory system. And I think anaesthetists sometimes, often overnight, if there's an anaesthetic reg, sometimes that's covering. I mean, we do have to support them to go through this process, as well as the theatre team there. So it's important to engage the family, but also we've got to, it's also important to do what's right by the patient first as well, because sometimes there's more urgency than there is to spend time with the family about trying to discuss all of these aspects. So it's a lot of it is, you can't, it's very, we protocolize as much as we can, but when we're out there, the protocolization aspect of things helps, because you can you can really spend your time kind of dealing with the non-protocol and the non-technical aspects.
Yeah. Okay. And I from the several documents that have been sent, I've noticed that the word assent has been used many times rather than the word consent. Is that a deliberate phrase?
Absolutely. So Brij and I both look after adult patients, so no one can consent on behalf of an adult in UK law. We seek assent from the family that they're obviously aware of the treatment that we're offering, why we're offering the treatment. If they're aware of any reason that the patient would not want that treatment, because obviously that would mean that you know, a different conversation would be needed. I've thankfully not had that issue, but it is just to really make sure that the family understand why we feel that this intervention is necessary, but also understand that it does come with inherent risks.
Yeah, absolutely. Okay. I think then I just wanted to talk about, because this is something that you mentioned, Brij, in your email, and some of the questions that maybe we could discuss. One thing you've written is the huge utility of lung CT and reducing associated transfer risks. Just break that into two parts. The huge utility of lung CT. Just explain that a little bit to me, if you could.
So one of the, I guess, aspects of when you're looking after patients with respiratory failure is that the X-ray is still a relatively 2D image, and often can be delayed in terms of its kind of progression. What we routinely do during after ECMO and even our conventional transfers is to take them through the CT scanner. And it goes back to understanding what the physiology is, and seeing is often believing. And so one of our protocols, for instance, mostly on patients with ECMO and with hemodynamic stability, is to do a recruitment CT scan to see effectively at a PEEP of 10 and then a PEEP incrementally up to around 40 to see for a short period of time with a quick CT run to see what recruitability there is in the CT. And we're getting more and more information about these aspects, but we do know that a significant proportion of patients don't respond to that. The other aspect is, again, the diagnosis of pneumothoraces, for instance, and particularly localized pneumothoraces that are kind of impacting the parenchyma. And furthermore, other, I guess, slightly looking at the non-infective picture. So a lot of patients that we are referred often can have underlying lung disease, particularly through smokers and COPD, and can have subclinical emphysema. And so it gives us a huge advantage in examining what these CT scans, how these CT scans relate to the physiology of the patient. So in our MDTs, we review the CT scans with our radiologists, as well as the ILD physicians that are there, and the intensivists that are there, to review exactly what progression of CT, what progression of injury there is with the CT scan. And in terms of reducing associated transfer risks, and I kind of alluded to that because actually when a patient is on 80–90% oxygen and it remains hypoxic and in a district general, you've got no exit strategy. It's very difficult to transfer patients to CT scan. And so one of the things that we have done not infrequently is to go there. And even if we feel that the patient may not be for ECMO, we will facilitate the team there to going through the CT scan.
This is at the referring hospital. At the
referring hospital.
Yeah.
And that's simply because, well, actually, we've got, I think, the processes and the expertise and to be able to transfer that patient there and back, and for us to then liaise with the referring team. And I think that's what I mean by, I guess, the utility of lung CT. I think we underutilize lung CT scans, and then obviously once you've done a lung CT is to send it to your severe respiratory failure center. So even if we don't feel on referral that the patient that the team won't go out and won't muster and retrieve, or what we will ask the referrings, if there is a lung CT, to send us the images across to us such that we can review the CT scans and advise them in terms of potentially whether there's any immunomodulatory component, so particularly organizing pneumonia aspects that may be amenable to pulse methylprednisolone, whether there's any underlying interstitial lung disease pattern, whether there's a huge emphysematous component. So I think that's what I mean by that.
Okay. Just talking about PEEP, you mentioned it briefly there that we can go 10 centimeters per PEEP up to, I think you said 40. When do you make a decision between raising the PEEP or proning the patient or indeed starting them down the Aprv pathway. And I know Aprv it seems to be coming up a lot discussion-wise at the minute. There was the recent paper that was a small centre study, but did seem to demonstrate that perhaps there was some advantage to Aprv over low tidal volumes. When you as a clinician, I'll hand this one over to Susan. Actually, you as a clinician, Susie, when do you decide that Peep is preferable to Aprv or vice versa?
That's probably the least easy question to answer. Thank you, Jonathan.
Okay.
And a lot of the, I mean, and I'm making light of it because a lot of it depends on what the patient is in front of you, and actually what you're using one patient works well, and what you're using the next patient work well. So, and it's being able to spend time with that patient and work out what does work for that patient. We find that increasing levels of Peep may be helpful in certain people in recruitability. Sometimes we find that those patients then run into trouble with CO2 retention, etc. So that's always a balance of where we go. Aprv, again, is one of those things that works very well in some patients, but seems not to work in other patients. If you've got a very sick patient, perhaps if they've got sepsis as their background, and you're keeping them purposely very flat on sedation, paralysed, then certainly in my experience, in my hands, Aprv doesn't really seem to work for those patients so well. Aprv tends to work better in patients who are spontaneously ventilating, and in those, and it tends to be in those in the obese and above category. It seems to work slightly better than just keep going up with the Peep, because they seem to tolerate the hemodynamic instability, as it were, caused by those increasing levels of Peep better on Aprv.
Okay, sorry to throw that one in your direction, but let's not give him a complete let out then. Brij, your views on that topic?
So I think so again, it depends on what you're trying to achieve in a way. So with Peep, that's a routine thing that a lot of, most all intensive cares are used to.
They're used to low levels of Peep.
Exactly.
I don't think many centres are used to high. I would suggest that most intensive cares across the country probably don't go much higher than 10.
No, so actually in the UK in general, compared to Europe, the Peep ladder itself is less utilised. But in terms of Peep, it comes down to where you think the right Peep is. And it goes back to whether we think the way in which people do recruitment manoeuvres. Now, the way I do recruitment manoeuvres is I don't do an acute 40 centimeters water up for 40 seconds, because the acuity of the impact of that on the cardiovascular system is huge. So an incremental Peep maneuver over, let's say half an hour to an hour is what I would practice. And then maintaining that Peep and getting optimal Peep and using the hysteresis and understanding that. But I would say more importantly is that Peep level and that optimization may be different in an hour's time as the disease progresses. And I think it's always that yo-yoing from the bedside or the office to the ventilator. That has to happen for us to optimize these patients quite early on. With regards to Aprv, the one single center study which showed an outcome benefit, I think it was a Chinese center, it was a very early implementation of Aprv. And so the open lung effect early on in most patients is probably present. The impact of Peep is probably there because the disease hasn't progressed as quickly. I think
they were using a P low that's unusual as well, weren't they?
Exactly.
I think they were using a P low of 5 rather than a 0 P low. Yeah. So I think that was a bit unusual, wasn't it?
That was. So so we don't routinely do Aprv here because I think the lung sees the pressure and you try and open it up, but it ultimately I would review that as a rescue strategy. whereby we don't understand the stress and the strain relationship that APRV delivers into the lung parenchyma. And I think there's a huge amount of stress that's there, but also strain, because your release volume does strain the alveoli. And so it does deform the alveoli, and that's what you're hoping for, right? But to try and get some gas exchange. But you also hit a plateau with APRV where your CO2 removal becomes potentially a problem, because you're either over distended certain units, or you're just not able to get enough minute ventilation. So I tend to advise caution with APRV, particularly later on in the disease process.
I certainly think, and this is just purely from my point of view, that I think sometimes when you're getting a patient who's that sick in a DGH who aren't used to proning patients, I think sometimes APRV seems like the easier and the quicker option. And I had this discussion with one of my colleagues over at Heartlands Hospital in Birmingham, who said that proning a patient, even in an experienced centre, requires a lot of staff. And sometimes if you're a smaller hospital, you almost need to wait for the handover of staff to get enough bodies together to do the proning in the first place. Whereas, if that handover period isn't going to happen for some time, actually trying the APRV route seems to be the only other option that you've got. It doesn't seem necessarily the soundest clinical reason to do it, but sometimes you're left in that situation where it is the only thing you can try.
Yeah, and I think we do have to be pragmatic about what's achievable and what each centre, and that's what I alluded to right at the start of this, is knowing what our referring centres can and can't do, and being very open with the referring clinician. What's your level of comfort? Are you happy to try and prone this patient, manage this patient overnight, or are you not? And whilst we think that there may be room for manoeuvre without actually needing to cannulate from ECMO, that does rely on the clinician there being able to and comfortable following our advice.
Yeah, absolutely. The other issue that I picked up on some of the information you sent me, and I think this is an interesting one as well, bearing in mind that there seems to be a lot of debate going on at the moment about fluids. Of course, we're going to get to fluids at some point. Is that we're as a group of professionals trying to work out both when to give fluids and, more importantly, when to stop giving fluids. Now, one of the things that you said in the PowerPoint that you sent me was that we need to keep them crispy dry is I think the phrase that's used, and that involves things like frusemide drives. When is an important moment to actually start this drying out process? And again, I suspect you're going to say it depends on the patient, and probably of course it does. But how keen would you be, perhaps is a better question, how keen would you be to dry the patient out if I was to refer them to you?
So yes, as you rightly point out, it is going to be patient dependent. It's going to depend on where they are in their disease process. If they are coming in their acute phase of sepsis, and they're obviously a long way behind on their volume and you're having to give them fluid. Obviously, trying to take fluid off a patient in that situation, you are going to buy yourself more trouble. So it's about working out at what point in their disease process they are at. But if you're referring them at sort of day 5, 6, 7, and they're over their very acute SIRS response, if that is the etiology of their disease, you'll often find by that point there'll be many litres positive, and we get referred people who are sort of 12+ litres positive, within that first 4 or 5 days. So it's really at that point, when they've got some hemodynamic stability, that you can start taking the fluid off. And even if that means reintroducing a little bit of vasopressor to allow you to take some of that fluid off, is sometimes helpful. I'd also advocate using CVVH to do that early on, because it's gentler, it's slightly more, technically more cumbersome than a frusemide infusion, but it's probably going to give you much more consistent fluid removal.
And presumably this is something you'll be doing to them when you get them to your centre as well.
Absolutely.
Yeah. Okay. So, and briefly, because I'm aware I've taken up a lot of your very precious time, briefly, I just want to talk about, we've talked about what happens to them once they're at the referring centre, once they've gone through the referral process, some of the things that you would want in place. We've talked about the cannulation process that may or may not take part at the actual referring centre. We've talked about the fact that you may or may not actually cannulate them at all. Once you've got them, let's assume that they go on to ECMO and they disappear from the referring centre. I'm sure probably some of the referring centres might appreciate knowing what actually happens perhaps in the first 12 to 24 hours to those patients as a routine once you get them to your particular centre. Brij, what is there things that you would always do to the patients as they arrive at your centre?
Yep, so as soon as they're on ECMO, we put them on lung protective ventilation, or as lung protective as you can do. We would then CT them throughout, and that's effectively a whole body CT, particularly a CT head. That's one of our routine things that we do to exclude intracranial pathology and intracranial hemorrhage, particularly because of the risks of bleeding. And so it reassures us that there is if there is no bleed there, and we can run with a heparin infusion. But if there is a bleed there, the ECMO circuits are so much more robust now than they were 5-10 years ago that we can run patients off of heparin as a result, and evaluate them neurologically once we're able to do a sedation hold. Other things that we do, I think you can't underestimate the value of the nursing staff that are there. There are 2 nurses usually by the bedside on an ECMO patient. They assist in all aspects of ECMO care. And in terms of the medical team, we would do routinely a bronchoscopy and take samples, particularly aiming towards the areas that are diseased according to the CT scan. And we have an ECMO screen to send off any autoimmune and tests that routinely with respect to severe respiratory failure, but also other tests. If we think the patient's immunocompromised, we will send off a retroviral screen. We'll send off the usual screens for community-acquired pneumonias and blood tests and blood cultures. And so all of these processes kind of give us, that just happens within the first 12 to 24 hours. And usually it's a day of stability within the first 12 to 24 hours to try and understand the physiology of the patient and the trajectory of the patient.
And how quickly, once you've got them in your centre, would you hope to see the ECMO having some beneficial effects on their physiology or their gases? Let's say that. So, Susan.
Yeah. So often immediately post cannulation, you can have a patient who's saturating in the sort of 70s, for example, and actually as soon as you're cannulated, you'll see an improvement in your SATs very quickly. Usually, once you've got them onto the transfer trolley and things, within the first half an hour, if they're going to have another sort of SIRS responses in response to being on the ECMO circuit, that's when you might have a little bit of wobble time, and your vasopressors might need tweaking. But usually, in terms of hemodynamics, once you're able to rein the ventilation strategy back somewhat, oxygenate the myocardium better, often by the time we get back to Glenfield, within the first hour or 2, you can usually see quite a significant impact on the amount of inotrope and vasopressor requirements you're needing, and obviously that will then, we hope, come off over the preceding few days, and that effect can be actually quite profound.
Okay, I think I'm going to draw us to a close, because a hugely valuable information. It's given a massive insight into a lot of the things that you do. I think it probably help DGHs try and understand. I know that you have a lovely referral pathway, certainly on the Glenfield site. I've not looked at the one on the Bromfield site, if I'm honest, Brij, mainly because I don't need to, because you're not referring. I'm not referring centre to you, but I would imagine, are there a lot of resources on your sites that people could go to, Brij, for example?
No, absolutely. So the Royal Brompton and Harefield Trust webpage has an ECMO site, but also the referral pathway, i.e. the hospital-to-home.nhs.uk, also has a lot of information with respect to severe respiratory failure care. There's a video on proning on there, and a lot of other aspects that a retrieval team would need potentially in terms of once they're called to the referring centre. So our feedback from the referrers has been very positive with that, and particularly the nice thing about that is that they can, once the patient is discharged back to the referring centre and transferred back, then the whole multidisciplinary team also inputs into that pathway. So it really does stretch across organisations.
Right, and a question I didn't ask, and Susan, I'll put this one to you, but I would imagine Brij is exactly the same. Even if it's just for advice and support, it's always a call that can be made, presumably, to an ECMO centre. And sometimes I would imagine you're going to leave a patient there, but maybe with the proviso that give us a call in the morning, we'll see how we go, we can offer a bit more advice, and we can take it from there.
Absolutely. So always very happy to be called and ask advice. If that advice can possibly be at 4 o'clock in the afternoon rather than 4 o'clock in the morning, yeah. I'm not gonna lie, that would be nice. But no, very happy at any time of the day or night to obviously discuss these patients if you're struggling clinically with them. And quite rightly, we follow that up with a sort of written email to kind of consolidate the advice, but also obviously that's then a record for the patient's notes. But in addition, if we think the patient is a candidate for ECMO, but they're just not quite there yet, you know, we're going to give some advice and see how they respond to some of the treatments we might suggest.
Right.
Then yes, we'll follow that up the following day. Clearly, if we feel that they're not a candidate for ECMO, we'll offer advice that is, we hope, useful to the referring hospital, and then close that case from there.
Excellent. Okay. Quick question to you, Susan. Do you know Hannah Conway?
I do.
You do? Okay. The reason I ask is because we are going to be having a regional ACCP meeting at Warwick, I think, in November this year, and I just wondered whether we might interest you in coming to speak to some of the ACCPs at that time, if you were free.
Yeah, very happy to do that.
Excellent. Okay, well, I'll chase Hannah and she can chase you and we can organise that.
Yeah, she only lives around the corner.
Okay, excellent. Okay, well, thank you both very, very much. I was hoping Shagan might have joined us, but unfortunately, I think he's had elsewhere to go. But that's really, really useful. Lots of very good insights, and I'm very grateful to you both for talking to me. And maybe we can address ECMO issues again in another couple of years and just see where the changes have taken us.
Absolutely. Thanks, Jonathan. Thanks so much for the invite.
No, thank you very much, and thanks for taking time to join me.
Cheers. I'll see you soon, Brij.
Take care. All right, see you next week.
Bye. Bye-bye.